Hi, I'm Professor Tom Wainwright. I'm a physiotherapist from the United Kingdom. I'm going to be talking about IRAS and spine surgery, and specifically about the physiotherapy elements. I've been involved in enhanced recovery for over 15 years, as a manager, as a clinician, and more latterly as a clinical academic researching different elements of enhanced recovery. In this session, I'm going to talk about an introduction to enhanced recovery. I'm going to remind you of the underlying principles of enhanced recovery, the components, and with specific relevance, some of the early studies looking at enhanced recovery in spinal surgery. I'm then going to examine my own profession's practice and that of physical therapy to see how we can improve things in the future for enhanced recovery in spine surgery. So as you'll be familiar with, Professor Henrik Kellett was the pioneer of fast-track or enhanced recovery. And he talked about enhanced recovery as being a multimodal approach, similar to that of care bundles, with the aim of minimising the surgical stress response. And this is true for all procedures that are adopting enhanced recovery. We want to modulate the surgical stress response and reduce the surgical infarct. As we see on this graph here, the natural recovery line being the red one, and we want to minimise that dip through this multimodal intervention using optimised and opioid-sparing analgesia and anaesthetic techniques, early returning to feeding and hydration after the operation, and crucially, early mobilisation. And underpinning this early work from Professor Henrik were three underlying questions that we still need to ask ourselves today. Can every operation be ambulatory? Why is the patient still in hospital today? And lastly, what is it that we cannot control or optimise for our patients? And these questions are really helping us to pursue how we can achieve a pain and risk-free surgery for all our patients. So if we look a bit deeper at the components of enhanced recovery, these hold weight, and this original diagram is perhaps one we should be returning to at the moment to remind ourselves of the simplicity of enhanced recovery. At the top, you see the emphasis on a multimodal, multidisciplinary approach, and this is crucial. At the bottom, the aim of an accelerated recovery and reduced post-op morbidity for our patients. And then we have the preoperative elements, education, optimisation of factors such as anemia, cessation of smoking and alcohol where indicated, minimising the surgical stress response in the operating theatre, minimally invasive techniques to surgery, but also a multimodal approach and a regional approach to anaesthesia and analgesia. That ensures optimal pain relief in the early post-operative stages so that we can mobilise and start rehabilitation early after surgery. And of course, we also need to remember key nursing elements such as early feeding and early hydration. These components are well known to us and they should be repeated across all the different procedures. And spine surgery is no different. So why look at enhanced recovery in spinal surgery? There's strong evidence for the success of enhanced recovery across musculoskeletal surgery and in particular hip and knee replacement. And therefore there is a strong theoretical case for how we can improve spine surgery outcomes by utilising enhanced recovery. And this is emphasised by this graph on this slide that shows the variation in length of stay across different providers for routine spinal operations. This variation does not reflect a difference in case mix, but it reflects a difference in processes and pathways used within those hospitals. Back in 2015, I published an article examining the theoretical basis for how we could help to improve spinal surgery outcomes by implementing enhanced recovery. And at a similar time, my colleagues in a district general hospital in the UK were implementing enhanced recovery across the whole of their elective spinal service. This graph is very impressive. They took the principles that they'd learned from hip and knee replacements and adapted them to their spinal patients and reduced length of stay by approximately 3 days across all of their patients. In addition to this reduction of length of stay, they had excellent patient satisfaction and they actually reduced their readmission rate as well. A key element within their pathway was the importance of standardisation and providing expected discharge days to their patients. I've chosen to highlight this slide because they started to talk about their spinal procedures differently. Instead of naming these procedures as the difficult and complex surgical lexicon that they used in order to name their procedures, what they did is they started grouping procedures together so that they could be on similar multidisciplinary rehab or enhanced recovery pathways. They then agreed expected discharge days for these patients and formulated a pathway that fitted this discharge plan. So they took the organisational learning from hip and knee replacement within their organisation. They made a simple and generic pathway for elective spine patients, emphasise on logistical and process optimisation, as well as some clinical additions to their pathway, such as the use of tranexamic acid. And so it was this combination of the right clinical decisions, applying the right evidence-based medicine where there was procedure-specific evidence available, but crucially accompanying that with the process and system changes. Because after all, our goal here is not to implement enhanced recovery. Our goal is to improve patient care. And to do that, we need to do the right things in the right way. And that's vitally important, not just for spinal surgery, but for all procedures across IRAS. And it's not just routine elective cases that can be done. If we look at this idiopathic scoliosis work from the United States, again published at a similar time around 2015, they found benefits to their patients in terms of improved pain control, so the reduced need for opioid and analgesics in these young patients, and also an improvement to length of stay. And this is for complex multi-level surgery in teenage patients. And if you want more details of this study, specifically the recipes, the rationales, and all of the details of their pathways, I recommend you go onto this website where they've given hyperlinks and all the instructions on how they achieved their pathway. So, there's strong evidence to support the adoption of IRAS pathways across a broad range of spine surgery procedures. There is emerging research to suggest that IRAS principles can have the same effect in spine surgery, and the number of spinal publications in enhanced recovery is going up month by month. And there may be a role for procedure-specific enhanced recovery guidelines to help accelerate this spread and adoption. But we need to be careful that it's not going to be one guideline for all spinal surgery. We need to segregate and look at different spinal procedures one by one so that we can adapt and come up with procedure-specific advice. One such example of that is the recent IRAS Society guidelines for lumbar surgery. These are available via the publication and are summarised in this diagram. And I'm sure you'll be going through all of these elements more in your training of the implementation programme. That's why I'm going to focus now on the physical therapy elements of enhanced recovery programmes in spine. What do we currently do and what can be further optimised? I'm going to look at prehabilitation, pre-op education and the patient information that we provide to patients, and then early mobilisation, rehabilitation and return to activity. And actually when I examine my practice and the practice of the hospitals that I work in and also of those in the UK, there's significant scope for improvement. So what about prehabilitation? Well, just like other surgical specialties, at the moment it's a good concept, but the jury is still out. Prehabilitation, remember, is exercise, nutritional optimisation and psychological optimisation. Things that should actually be suitable for a certain number of spinal patients. However, the results from this systematic review show at the moment there is insignificant evidence to mean that we should be routinely doing this for every patient having spinal surgery. But that's not to say high risk or particularly identified patients may not benefit from this in the future. Preoperative education is a part of all of the guidelines and is something that is recommended across all of the procedures involved in enhanced recovery. However, when you look critically at the evidence, it doesn't show that it reduces length of stay in spinal surgery. However, it's safe to deliver, patients like it, and there may be some psychological benefits that are seen within the spinal literature. How about early mobilisation? Well, in our narrative review, we strongly recommend the need for early mobilisation. This is extremely important, and early mobilisation is not just important in terms of recovering function, but it's also really important as an analgesic intervention. Getting patients to move and walk will reduce their pain, and there will be a positive cycle of increasing mobility and achievement of discharge criteria. Early physical therapy is also recommended, but the details and the rationale and the exercises as part of it still need to be confirmed. However, my personal view is that in the early stages we should focus on walking and functional activities. These are the things that will help patients more quickly return to day-to-day life, and then physical therapy may then be required on a patient-by-patient basis to return to their specific jobs or different activities of daily living. But we need to be careful. We need to be careful to personalise this rehabilitation and also this information. We published a study looking at patient information leaflets for lumbar spine surgery. But there's a missed opportunity here. We used the Discern tool. This is a specific instrument for looking at the quality of written information given to patients. And there was a massive variation between the quality of information given across hospitals. So this is something that is within our control. If we go back to Kellett's 3 questions, what is it that we cannot control? We can definitely control giving better written information to patients. And this will help to manage their expectation and also get them to understand the benefits of early mobilisation and quicker recovery. And when we're putting together this information, we need to think about the details of what we say around returning to activities and returning to different physical exercise and lifestyle options. When we look critically at this again in another paper, there was a massive variation with what hospitals said that patients could return to different activities. Sometimes it was 2 weeks, sometimes it was 2 months for the same activity. I think we can standardise this, and we need to acknowledge that what we provide in our patient information needs to be understood by the patients, and it needs to fit with what the evidence says. So, there's plenty of scope to improve interventions related to physical therapy or physiotherapy within spinal pathways. But this is exciting. It means there's stuff to improve so that we can help our patients in the future. So, in summary, I've provided an introduction to enhanced recovery and reminded you of the underlying principles and components of enhanced recovery. I've talked specifically about the early studies showing benefit of enhanced recovery in spinal surgery and highlighted the newly published guidelines in lumbar spine surgery from the ERAS Society. I've then examined my own practice around physical therapy and highlighted that there are components where we play a vital role, but that we also need to optimise and know more about how to improve in the future. I urge the other professions, nurses, anaesthetists and surgeons, as some examples, to also critically examine their own practice and see how they can optimise things for their patients. Thank you for your attention and good luck with your programme.